Hello, good afternoon, everyone. This is Dr. Major Harshita Surange from IPSC Pain and Spine Hospital. I'm wanting to share a very interesting case of a patient who came to us with pain in the right lower abdomen. The patient was 30 years old. She had pain in the right lower abdomen since last 8 years. And since it was such a long duration, she had changed multiple doctors and had got multiple tests done. She had got the ultrasound abdomen done, which was normal except for mild polycystic ovaries. A CT abdomen revealed minimal free fluid in the pelvis, which was again not significant. She had undergone multiple short courses of antibiotics and also had undergone repeat diagnostic laparoscopy, which turned out to be normal. When she visited us at IPSC, we took a detailed history and came to know that it was insidious in origin. It was burning, shooting pain in the right lower abdomen, which was aggravated with physical movements. History of the further detailed history gave us a history of that the patient had undergone laparoscopic surgery for ovarian cyst around 10 years back, and post that only she had developed the pain. We made a clinical diagnosis of nerve entrapment and decided to go in for a ultrasound using a high resolution probe. So these are the different types of probe. We use the high resolution probe, and with the high resolution probe, we place the probe over the anterior abdominal wall in the midline. And here what you can see is the skin, the subcutaneous tissue. This muscle is the right recti, and this here are the anterior abdominal wall muscle, the external oblique and the internal oblique. Now here, just underneath the anterior rectus sheath, a hypoechoic area can be seen. This black hypoechoic area was tender to probe, and the patient could experience the similar type of pain which she keeps experiencing. We manipulated the probe to follow up or open up the nerve if it is at all attached to a nerve, and we could manage to open up a small nerve which was not only entering the neuroma but also exiting the neuroma. And here in this image you can see the nerve which is coming up right till the neuroma and is also exiting, and this is over the right recti. So this we came to a diagnosis that this is a case of anterior cutaneous nerve entrapment syndrome, that is the acne syndrome. Now, what is acne syndrome? The ventral rami of T6 to T12 travel in the transverse abdominis plane and give out two branches, that is the lateral cutaneous nerve and the anterior cutaneous nerve. If you see it in this diagram, these are the ventral rami, and it gives out a lateral cutaneous branch and the anterior cutaneous branch, which are responsible for the sensory supply. So these nerves, they travel through the muscle plane. And now, if here I'm talking about the anterior cutaneous nerve, this is traveling through the rectus sheath, through the rectus sheath and through the recti muscle. And during this course of travel, it has got entrapped and formed a neuroma. So if we talk about a coronal anatomy, then this is the recti, and if we take a cross section here, then what you can see that this is the anterior cutaneous nerve, and see this is the way it travels over in the rectus sheath, and this gets entrapped, and the pain is aggravated on movements. So now in this illustration, what you can see is the anterior cutaneous nerve traveling in the tap plane, and the exit or the terminal branch has a variable course. It can travel over the recti, it can travel through the recti, it can travel under the deeper surface of the recti and emerge out over the anterior rectus sheath. So with a varied travel course, it can get entrapped within the recti or underneath the facial plane. So we came to a diagnosis of acne syndrome, and to conclude, this is not an uncommon case. Almost 1 in 1,800 patients suffer from acne syndrome. The age groups are 15 to 20 and 35 to 45 years. Mostly T9 to T12 dermatomes are involved. And the bad part is only 2% cases get the correct diagnosis. If the conservative treatment fails, then hydrodissection and release of the nerve is the treatment of choice. And if that too fails, then our radiofrequency ablation of the neuroma can be done. Thanks for watching.